Alright, I'm Coralie Fuss, and this is my Peds presentation on AM, 17-year-old male. AM was brought to SMF via life flight due to a head-on collision motor vehicle accident. Patient was going 60 and the other driver was going 80. It was reported that he was wearing his seatbelt. Patient has a history of chronic otitis media, asthma, obesity, eczema that's poorly taken care of, dysthymic disorder, depression with a previous suicide attempt, history of drug abuse, and was positive for THC and benzos on arrival, and he smokes cigarettes and drinks alcohol occasionally. Patient's mother is incarcerated, and grandmother has been legal guardian since he was 1 year old. He also lives with his younger sister and brother in Minnesota. Patient was admitted to the PICU on the 18th, where they found his head CT was negative, C-spine was clear, but he did have 10 fractures, a right femoral neck fracture, right femoral shaft fracture, right tibial plateau fracture, right pylon fracture, right proximal thumb fracture, right olecranon fracture, pubic symphysis disruption, left sacral ala fracture, right iliac wing fracture, and a left distal radius fracture. Blood cultures were also drawn, and it showed methicillin-sensitive Staph aureus bacteremia, which he was treated with Vanco. CT showed concern for lymphadenopathy, which are just swollen lymph nodes. There were many seen all over on the CT. They are doing tests to see if it could be lymphoproliferative disorder versus leukemia. So they will do further testing for that. He went down to the OR for multiple fixations. On the 19th, he became tachypnic and tachycardic and satting at 93% on 2 liters of nasal cannula. Found to have a left lung collapse associated with hypoxia. He went down for a bronchoscopy and bronchoalveolar lavage to remove multiple mucus plugs. On the 20th, he deteriorated. CT showed free air with possible bowel and stomach perforation. He was still tachycardic and tachypnic, was intubated and sedated after this surgery. He was down to the OR for an exploratory laparotomy where they found necrotic stomach tissue along with the perforated bowel. So they removed some bowel and did a resection / washout. He was then diagnosed with septic shock, refractory in OR, requiring cobalamin and norepinephrine. He also received bicarb and fluid boluses with 2 units of blood. They did not close his abdomen. They were unable to. They put a negative pressure wound therapy vacuum on at 125 millimeters per mercury of continuous suction. And he was also given fresh frozen plasma ×2 and an arterial line. On the 21st, he had a repeat exploratory laparotomy, and he was closed with a wound vac again. Also did a lymph node biopsy and a chest tube placement due to the lung collapse. Now to discuss the pathophysiology of everything that's going on with AM. A fracture is a disruption or break in the continuity of a bone. Traumatic injuries can cause this. In this case, it was the motor vehicle accident for him. They are classified in many ways. They can be open or closed, displaced or non-displaced. Open is when the skin is broken and the bone is exposed, and a closed fracture is when the skin is intact over the sites. His were all closed, so the skin was intact over the sites. They can also be described as displaced or non-displaced. A displaced fracture is when the 2 ends of the broken bone separate and are not in the normal position they usually are, and it can mean that there are more than 2 fragments. A non-displaced fracture is when the bone fragments stay in alignment, and AMs were displaced. A patient with a bone fracture can experience localized pain, decreased function, and the inability to bear weight. Patient also had a bowel perforation. This happens from a hole or tear in the mucosal layers of the intestinal tract, can result in air and digestive contents entering the peritoneal cavity, can be acidic gastric contents or fecal matter depending on the area of the perforation. If it's proximal, it'll be more acidic, and if it is distal, it'll be more fecal matter. Pain can be gradual or sudden, may have abdominal distension and abdominal muscular rigidity. Nausea, vomiting, guarding, tachycardia, tachypnea, fever are some signs you may see. Can cause a life-threatening infection. The bowel will become ischemic and then necrotic as the blood flow to the bowel is blocked. And when they went in for surgery, they did see that he had a necrotic stomach. He also went into septic shock in the OR. Septic shock is a systemic inflammation that can lead to abnormalities in vascular tone and distributive shock. This can lead to abnormal distribution of blood flow, and they may develop vasodilation, which can lead to hypotension and inadequate tissue perfusion, which causes the necrotic stomach, and now the blood is shunting to more important organs like the brain, heart, and the lungs. Septic shock includes a microorganism that enters the body, and the immune or inflammatory responses are triggered but exaggerated. Pro-inflammatory and anti-inflammatory responses, coagulation increases, fibrinolysis decreases, endotoxins stimulate cytokines, which include the tumor necrosis factor, interleukin-1, and platelet activating factors. The platelet activating factors lead to microthrombi and obstruction of microvasculature, damage to endothelium, increased capillary permeability, and neutrophil or platelet aggregation. Vasodilation, maldistribution of blood flow, and myocardial depression are the three pathophysiological effects of septic shock. Hypovolemia and hypotension occur because of the vasodilation and the shifting of fluids out of the intravascular space. There's poor oxygen delivery and tissue hypoxia. Ejection fraction is decreased. The ventricles dilate to maintain stroke volume. The patient will initially hyperventilate as a compensatory mechanism, which puts them into respiratory alkalosis, but when the patient is unable to compensate, it turns into respiratory acidosis, and they will need to be intubated and mechanically ventilated. Alright, now to compare clinical manifestations of septic shock from the textbook to what AM presented with. Persistent hypotension, tissue hypoxia, positive blood cultures, tachycardia, increased or decreased temp, crackles in the lungs, warm or cool, increased white blood cells, and increased lactate and uric acid. AM had all of those. Persistent hypotension, he was having soft blood pressures, tissue hypoxia, positive blood cultures were gram-positive methicillin-sensitive Staphylococcus aureus bacteremia. Tachycardia, he was tachy to the 140s. Increased temp up to 103. Crackles in the lungs, they were suctioned and cleared for the most part. He was warm, had a very high temperature, used cooling device to keep body at a certain temperature. Increased white blood cells, normal is between 4.0 and 11.0, and his was 16.1, which indicates infection. And increased lactate and uric acid. This could have also been from the trauma or possible lymphoma. Medications he's on. Presidex is a sedative to keep him sedated. Fentanyl is for severe pain. It's a narcotic. He's on TPN since he's not eating. 75 milliliters an hour over 24 hours. Piperacillin is for the bowel perforation. Lorazepam for agitation. Fentanyl for sedation and pain. Calcium gluconate for ionized calcium less than 1.12. Bacitracin ointment, hydrophor ointment. Those two are both for his eczema, and then also the road rash that he acquired from the accident, and then the chlorhexidine, which is for oral cares. Other treatments and interventions, chest tube to reduce the air in the pleural space due to the collapsed lung. When the air pressure decreases, the lung will re-expand and heal. The endotracheal tube, since he's ventilator dependent after surgery, and so that they don't have to intubate him every time he goes down for surgery now. An NG to get the infected gastric contents out, and also for food. Negative pressure therapy vacuum is what they closed his abdomen with. The ART line is infusing feedings and for some medication infusions. The IPV therapy is every 6 hours, and that's to shake up the secretions in the lungs and then try to suction them out. It's called intrapulmonary percussive ventilation. It sends fast bursts of air that open the airways. Turner repoem every 2 hours to avoid pressure injuries since he's dependent with everything at the moment. A Meplex border to sacrum to avoid a pressure injury. Heel lift boots to prevent pressure injuries to heels. Splint braces to decrease movement to fractured areas and to help heal. Of course, surgery, immobilizers to decrease movement to fractured areas and to help heal, non-violent restraints so he does not pull the endotracheal tube out when he gets irritated with it, catheter, he's incontinent, pelvic binder to stabilize pelvis until surgery, blood cultures daily to assess for the bacteremia and assess the sepsis, and vasopressors. Patient was on vasopressors to control the hypotension due to the septic shock. They need to be commenced within the first hour to achieve a MAP of greater than or equal to 65. Growth and development for AM. He is considered an adolescent, which is 13 to 20 years old, and he is 17. Reproduction is possible at this stage. Patient is sexually active, as stated in his chart. Growth spurts, secondary sexual organ development and changes, acne, body odor are some physical changes that can happen. I was unable to assess cognitive changes due to sedation and ventilator dependency, but before this accident, patient was in school and also involved and enjoyed sports. He should be able to base his new knowledge on past experiences, engage in abstract thinking and problem solving, and be independent on decision making to build skills. He is in the identity versus role confusion stage, develop a sense of personal identity, and he should depend more on peers and become independent from parents and family. Priority interventions could include mental health. He is stated to be depressed and had a previous suicide attempt. Car safety, which is obviously an issue, but patient was wearing a seatbelt, so he is aware of certain safety. Tobacco and alcohol, patient does engage in these activities along with other drugs, and sex education since patient is sexually active. Some discharge, next steps and goals. They're going to collect blood cultures until patient is free of infection from the methicillin-sensitive Staphylococcus aureus bacteremia. After the blood cultures are clear 3 times, they plan to go in and do surgery on the fractures, and they're not sure if they're going to do one surgery or multiple. It depends on patient status. After that, they're going to try to wean the patient off the vent, and eventually extubate when the patient is able to breathe effectively on his own. Wean off the sedatives. Patient will eventually have the catheter taken out, chest tube out, the negative pressure vacuum off, art line, all of that good stuff. Start PT and OT, but right now, goal is to keep the patient stable. And here are my references.